Hello, Sean. How are you? Hello, good evening, Sean. How are you?
I'm Dr. Kazmi. I'm fine. How are you today?
Can you hear me?
Yeah, I can hear you. Can you hear me?
Okay, let me. Can't hear you. But see. Just give me a moment. I can't hear you. Let's see what's going on. Oh, I need to change this to headphone. Okay. Can you say a few words so I can just check the headphones?
Sorry?
Okay, fine. So, can you hear me clearly?
Yes, I can hear you, but you have some echo, but it's fine.
Okay, fine. So, fine. So, today, I think we'll be doing one clinical examination station, and then we will be going on to an extended history and clinical examination, and then communication and a video station. So we are going to do 4 according to the exam format, exactly in the time that they allot us. Is that clear?
That's a lot.
Okay, fine. So we'll be doing it in a discussion way as well, like and but obviously we will be looking into the time. So let me share my screen, and then we start. Okay, so hopefully you can. Okay, can you see the screen now?
Yes, I can.
Yes. Okay, fine. So this would be basically a 9-minute station, and this gives you basically before the station starts. This is known as a clinical examination station, and there will be 2 stations in the actual exam. So in the circuit, there will be 2 stations, each of 9 minutes. And I think in that 9 minutes, you've got 6 minutes for doing the examination part, then 3 minutes for discussion with the examiner. And again, this is a virtual examination. It means there will be no real patient. You'll be given a picture like this, or you might be shown a photo. You might be shown, I think it's probably would be photos, and with that, there will be a task rather than showing you a video or something, because videos are for the video station. So this is a sample clinical examination station, 9-minute station. And before that, this is the instructions. That the instruction says this 12-year-old girl has been complaining of numbness of both legs. So the instruction says, please examine the lower limbs of this girl neurologically. So you have to do a neurological examination of the lower limbs. The examiner will give you clues as you proceed with the examination. Then after 6 minutes, you will be having 3 minutes to discuss your findings and formulate a differential diagnosis. So you have got 2 minutes to read this. Think you what you want to do, and then we will start. Is that clear?
Yeah.
Okay, fine. So just give it a read. We've got 2 minutes, and you also you can make your notes as you go along, and I would also be making notes with me as well.
Okay, can I start?
Okay, fine. So let me look at the time. The time is 8:05. Okay, so the 9 minutes starts right now. So can you please start the neurological examination of this girl's lower limbs?
Okay. I'd like to introduce myself. My name is Shay. I'm one of the general registrars, general doctors here. I've been asked to examine your lower limb because you are having a tingling sensation, numbness rather in your both legs. Is that correct? Yes.
Yes. Yes.
So, with your permission, I'd like to proceed with the examination.
Yes,
After
please.
seeking consent, I want to expose the patient adequately. The area that's going to be examined, I want to wear my um, apron and go wash my hands and then wear my gloves and
Okay.
then
Fine. So
make
just
sure.
assume that you have done all these things. You have been like the patient is properly exposed. You have disinfected your hands. Just proceed with the examination, please.
Okay. So I'd like to start by um, inspecting patient disposition in the bed. To start with spine position, I want to start inspection. I'll move at the edge of the bed and then have a thorough look at the legs. I'm looking for signs of muscle wasting,
Okay.
fasciculation,
Okay.
um,
Fine. So what do you see? The
pigmentation.
picture is in front of you. You are examining this girl from the front. What do you see?
Uh, Basically, there seems to be some there's hypopigmentation at the foot. So is it my eyes or are they just straps of shoes? Um,
So you
Color
said
is not very
hyperpigmentation. What else?
yeah, hyperpigmentation. Uh, that's about what I can see. The knees looked a bit. I don't know if they are knocked together or it's just a posture. Um,
What else?
yeah, she appears to have genome valgum. Um,
Okay, you're saying the genovalgum.
yeah,
Okay, fine.
that's it. That's the only thing I can see to refer.
What else would you like to do in the inspection part?
Um, we talked about fasciculation. We've talked about pigmentation, atrophy, muscle wasting. Um,
Okay, fine. So, uh, let's say there are no fasciculations.
okay. So I like to ask the patient if he feels pain anywhere, and then I like to
The
start
patient is
by
not in any pain. The patient is totally painless. Is not has she hasn't got any sort of pain anywhere at the moment.
okay. So I like to examine the tone in the knee
Okay.
and
How would you examine the tone?
so I put her in a relaxed position. I want to move my joints across the knee on
Would you like to
flexion and
examine?
extension.
Would you like to examine for the tone in standing position?
No, I said the patient is already in supine position.
Okay.
The
So the
position of
patient is
the patient is
okay.
pretty much there.
Okay. So
So,
where would you look for the tone?
so the knee, the ankle, and the hips.
Okay. And
So
how
I'll
would you do
go
that? How would
from
you do
the
that?
hip.
Can you briefly
I want to.
summarize the procedure of how you check for the tone at these three joints?
So I want to move a link starting from the hip. I want to move thigh across our hip on flexion and extension, and
Okay.
then check.
Fine. Would at this point would you like to give some instruction to the patient while you are checking for the tone?
I want to actually be relaxed, and then
Yeah. Okay. Good.
yeah,
Oh, fine. Okay.
yeah.
Once so you have looked at the tone. Okay. So the tone seems to be a bit low in the calf muscles, but it is normal in the thigh muscles and at the hip joint.
Tone is low in the calf muscles, right?
Yes.
And what else?
So in the thigh muscles, the tone is fine.
Thigh muscle is fine, but it's low in the calf.
Yes.
Okay. I like to now check for power on both sides. I
Okay,
first want to
how
ask the
would you
patient.
check? How you check for the power?
So I want to ask the patient if he can straight leg raise. If you can do that for the power, it's already about 4. And then if you can do that, then I want to put pressure on. Um, well, I'll check for the group of muscles to start with, but
Okay, so
if you
which
can
group of
straight leg
muscles would you
raise.
like to begin with?
So I want to start with the I can start with the quadriceps muscles, yeah, in front, and
Okay.
then I move to the hamstring.
Fine. So the muscle power in the calf muscles is 4/5, and in the thigh muscles it is 5/5.
Okay. So sorry. Okay. Um, I'd like to check for the reflex now, and then
Okay. Fine. So where would you check? Which reflexes would you like to check?
check for the reflex at the knee L2, L3, L,
Okay. Fine.
L1,
So
L2,
okay. So the
and then
knee.
I check at the ankle.
Okay. The
Yeah.
ankle reflexes are absent, but the knee reflexes are present.
Okay. 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 So after doing all that, well, if I'm sure, I'll palpate the calf to be sure that she doesn't have any pain in her calf. If she doesn't, I might try to elicit a clonus.
Okay.
If that's okay.
Okay. So the ankle clonus is not present.
Okay. So, okay. So after doing this, I want the patient to stand, and then I want to see her posture. Then I'll ask her to walk heel toe and then tiptoe walk around to check her gait.
Okay.
Then
So the
so
gait, the tiptoe, she can walk on the tiptoe, but she seems to be a bit unsteady.
mm,
And there feels to
okay,
be a high steppage gait as well.
high stepping gait. He said,
Both sides, yes.
on which side?
Both sides.
Both sides. Okay. Sorry, just before the walk, I want to check for joint position sense. Yeah, I want to check for joint position sense
Okay, so
using a
you are talking
tuning
about the
fork.
Romberg sign. Yes, so the Romberg sign seems to be positive because the patient is swaying excessively.
Okay, positive Romberg. Yeah, apart from the Romberg, I want to use a
Okay,
tuning
so the time
fork to check.
finishes here now. Your 6 minutes are up now. You've
Mm.
got 3 minutes. Can you just consolidate your examination findings and please tell me if you would like to do anything else?
So I was saying that I like to use the tuning fork. Ask her to close her eyes, and then I want to check for sensation. I ask her to close her eyes and tell me if she feels any touch. I like to check for deep and then light touch. I use a cotton wool to check for light touch across the dermatome areas, and then I use and I can use a needle to check for deep touch. So just to know
Anything
that's
else you would like to
comparison.
examine? Anything else you would like to examine?
Yeah, the joint position, since I asked her to close her eyes, I move her to down up and ask her what I'm doing, if she's able to isolate any other things. What else?
Okay, let's
Uh,
talk about the what do you think based on these findings, on your examination findings, looking at the picture and looking at the cues that you got in the examination, what do you think uh, could be the reason of that? Can you just give me your three differentials for this condition?
oh boy, the tough one. So some of the things I'm thinking about to be ataxic conditions, like which some of them could be genetic, I think.
Mhm.
Um, I'm not mistaken, but I'm not sure if you have Friedreich ataxia in women. I'm not sure. I'm not sure about that. It could be a deficiency of vitamin,
Mhm.
vitamin, vitamin B1. Yeah,
B12, you
deficiency of
mean to say basically B12.
B12, sorry, B12. Yeah,
Okay.
B12. So but that would be. I don't expect that in this age group because she's too young to be. Well, she's not too young to be an alcoholic, but
Okay.
it's a
Okay.
sign that shows much more later.
Mhm.
It's not
Okay.
common in
Fine.
this age group.
Tell
Um,
me about three investigations that you would like to do in this particular case.
I
Relevant
like to
investigations.
do.
Relevant investigations based on your findings.
Yeah, I like to do a nerve conduction study. I think I like to do what do you call it now? This muscle. muscle biopsy, that might actually be a muscle stimulation study or something like
When you
that.
say electromyography.
Electromyography, yeah, that's what I was trying to look for. And then I just do blood to see a borderline and maybe check for some antibodies if it's possible to do that. So we're thinking about immune conditions that can cause this.
Okay, so the time stops now for this station. Thank you very much for doing this presentation. So let me give you my feedback for this thing. So in the clinical examination station, basically you know, see, when they give the universal clue, so that is a lot of information over there. So that you have to take clues from there, and then you have to do rest. It was easy. Neurological examination is very structured. You just need to remember the way in which you would go. Looking at the picture, I mean, obviously you can see that this is the lower limbs from the front, and if you see, the first striking thing is that there is atrophy of the calf muscles. If you look at the thighs and you look at the calf muscles, it's what they call as a classic inverted champagne bottle appearance. When that comes
Mm.
into your mind inverted, obviously the first thing that should strike you is characteristic is hereditary sensory neuropathy type 1, which is also known as Charcot-Marie tooth disease. Okay.
Ah,
Peroneal muscular atrophy is also known as peroneal muscular atrophy.
the
So,
line is breaking, please.
pardon?
Sorry, the line is breaking. Sorry. You're saying atrophy, better jumping glass appearance, Charcot-Marie tooth disease, yeah?
Yes, which is also known as peroneal muscular atrophy. So
Yeah.
looking at the picture, that gives you a clue. Even if you can't pick that, you can see that there is atrophy of the the lower leg muscles. Then the other thing, when you look at that, I mean, from the inspection, obviously you would say, I would like to examine the child from the back as well. Because what are you looking at the back? You are looking for scars, any, what you call tendon lengthening scars, any operations. Okay, so you would look from the back as well. Sometimes it would be the opposite as well, like hypertrophy of the calf muscles, which goes more in favor of DMD, Duchenne muscular dystrophy,
Yeah.
or Becker's
Yeah.
muscular dystrophy, if that was the case of boy. Anyhow, the other thing is in examination, in inspection, if you look at the feet, so there is some degree of pes cavus as well. So high arched, high
Some
arches,
degree
which
of
are
what?
pes cavus, high arches of the feet.
Oh, okay.
Or if
Okay.
you are not sure, you would see, I would also
Ah,
like to look for the arches. And here the examiner would give the clue that this child has got pes cavus as well, has got high arches. And then when you get high arches and lower leg issues, then you are thinking of obviously of peroneal muscular atrophy, or maybe diseases in which the the lower what you call limb muscles might be atrophied. It could be like a spastic diplegic CP as well. But obviously, looking from the picture, you can't say unless until you had the picture, the full, the picture of the full patient. Anyhow, so you start with the inspection. So inspection, you are looking at the posture, you are looking at the position, you are looking at the color. Obviously, you mentioned all those things, that I'm looking at the color, and I looked at the probably there is some form of like degree of genu-valgum, which is probably relative, because obviously there is muscular atrophy as well. So it looks like pseudo sort of a genu-valgum as well. So looking at that, and then you would move on, like, you have to neurologically examine. So the first thing before you go on to, doing the, what you call the tone, the power, and the reflexes, the best thing you start with the gait, because the child is obviously standing. So say, with permission, I will ask the child if she's in pain. Obviously there is no pain, so I'll ask the child to take a few steps. So I would like to see a simple gait. I would like to see the child's tandem gait, like, heel toe, and then walking on the tiptoes and walking on the heels. Obviously, he would give you a clue that here the child has got a high steppage gait, and obviously because of peroneal muscular atrophy, they've got a high steppage gait. And the other thing is that they would be having a little bit of unsteadiness on their feet as well, because of the high arches, and obviously because of the distal sensory neuropathy as well. Then here you can also talk about, I would like to do the Romber test. So If the child is unsteady, if that unsteadiness is aggravated by the child, bringing their feet together and eyes closed, that goes more in favor of a peripheral neurological reason of ataxia rather than a central one. Because if Romberg is positive, it simply means neurodistal neurological reasons as compared to cerebellar reasons in which the Romberg sign is negative. So that gives you another clue that something is wrong peripherally. It's not in the central, it's not at least in the brain or in the cerebellum. It's somewhere down, either in the distal part of the spinal cord or in the peripheral nerves. So that would give you another clue. You are slowly and gradually moving in that direction. And then uh, once you have done the gait, then you have to look at the motor examination and the sensory examination. So obviously, motor is the first one. It can be easily done. Sensory, we don't do. We will just have to describe to the examiner that, no, I would like to take these sensations in a dermatomal pattern. So you should know, like, which are the, like, what is the, at least you can't remember all of them, but you should remember which is the sensation area for big toe, for the front of the calf muscle, front of the legs, back of the leg, front of the thigh, and back of the thigh. Just a few dermatomes. So you would say, okay, well, fine. I'll put the child on the couch, okay, and we'll start with tone. So remember TPR, like TPR is a very good acronym for this: tone, power, and reflexes. So how do you check for tone? You would ask the child to be completely relaxed. Say, don't help me, just be relaxed, okay? And then gradually what you do for hip joint, you'll just like lift the knee up, okay, and just leave it supple, okay? So see if it, like, tapping up, so it comes down or not. Similarly, you will joint against the ankle, around the ankle joint, you will just move the ankle around and see if there is any stiffness when you are trying to do these passive movements. And the same you do around the knee as well. So that would give you an idea about the tone. So as they told, the tone is low around the ankles, but it is normal around. So again, it is giving you an idea that something is not right around the calf muscle. Something is just related to the distal uh, muscles. So distal muscles could be anything. It could be like distal, what you call it, muscular dystrophies. Like some muscular dystrophies can also present that way, like DMD or Becker's muscular dystrophy. Or it could be neuromuscular reasons for that. So tone, then you check for the power. So power would be for the group of the muscles. So group of the muscles you should know, like for thighs, it would be the thigh flexors, thigh extensors, adductors, and abductors. So obviously you would put your hand and you will say, okay, well, fine. If the child can straight leg raise the test, okay, then it's fine. The flexors are fine. You can also ask him to like separate them. That would check the adductors as well. And you could put your hand beneath the child's thigh and say, press it down. That would give you an idea how is the power in the thigh extensors. Then you do the same thing with the knee joint as well. You ask to push them against pressure when you are putting pressure on the knee, or you will say, okay, well, fine. I would be pulling your leg forward at the knee joint. You push it, so that way you would be checking the power in the knee flexors and extensors. And the same thing you do in the ankle flexors and extensors as well. So it's easy, like two groups of muscles that give you the power and the power grading. So power is 5 or 4. 4 simply means that there is power against resistant to some extent, but not full. So it simply means that again their power is low in the calf muscles, which would mean your gastrocnemius soleus and your peroneal muscles, peroneus longus and peroneus brevis. Fine. So after doing that power, you will check for reflexes. So reflexes, deep tendon reflexes, knee reflexes are present, ankle reflexes are absent. So it simply means a distal neurological problem. You check for clonus as well as a part of that. Okay, fine. There was a mild clonus, or sorry, no clonus at all. So that again tells you that something is wrong in the distal, sort of neurological arc. Then after that, you would say by this time, probably you would have finished your 6 minutes and you would say, I would like to complete my examination by doing the sensation and the joint position proprioception, doing that on the lower limbs. and would like to complete my examination by doing a full neurological examination, checking the cranial nerves, checking the upper limbs and the higher centers as well. That is very important.
Okay.
You have to tell, because you have to complete your neurological exam. You've just looked at the legs, but there might be some other stigmata of this disease, elsewhere, which you need
Yeah.
to check.
Yeah.
So that's important, that you need to tell them that, I'll be doing this thing. And at the same time, you can say other things which are usually help you. Well, fine, then I can do any neurological examination. There are a few things. Say, I would like to plot the child's height and weight on centile charts. Works everywhere. So, like sort of a generic formula. Number
Mm,
two, I would like to check blood pressure. Again, works everywhere. Neurocutaneous syndrome, something you have to check. Number three, I would like to do fundoscopy.
mm.
These three things, you finish off your examination with this thing, like, you secured your pass. Then he might ask, okay, what are the differential diagnoses? So differential diagnosis of mild ataxia with Romberg positive with Peroneal. So you would say, okay, well, fine, it could be probably Frederick ataxia. Okay, Frederick ataxia is also like there is Romberg positive, and they've got an ataxic gait, and it's usually, the other is ataxia telangiectasia, but that usually presents at a very early stage, and that usually it's got cerebellar ataxia. So they've got like immunodeficiencies. There are history of like repeated infections, low immunoglobulins, telangiectasia appearing at an early age. So that usually presents at an early age. I mean, somebody won't go up to 12, 13 years of age. So you can say ataxia telangiectasia, Frederick ataxia, and hereditary sensory motor neuropathy type 1, which is also known as Charcot-Marie tooth disease. So that way, you can, like, impress the examiner that you know about these things, the causes of chronic muscular dystrophies or distal neurological problems with, with gait issues or with numbness. Other things that can present with distal neuropathy, sometimes you can say, okay, well, fine, heavy metal poisoning like lead toxicity can also present with distal neuropathies as well. But
Yeah.
obviously that would be very rare. So
Yeah.
again, but if you tell them, at least they would know that you've got the knowledge. Okay, fine. What relevant investigations would you do? So the relevant investigations, whenever there is a neurological involvement in distal, where you think
Shall we
either
say that
it's a
again?
muscular involvement or neurological. Three things. So number one, because you want to see the difference whether it's a neuropathy or whether it's a dystrophy, muscular problem or neurological problem.
Mm.
Okay, neurological problem, you need to do nerve conduction study.
Yeah.
Nerve conduction study, all the distal neuropathies like demyelinating disorders. Okay, distal demyelinating, that would, the nerve conduction studies would be, velocities would be affected in that. Number two is
Mm.
electromyography.
Mm.
Electromyography would tell you if there is problem with the neuromuscular junction or with the muscle itself.
Mm.
And number three, a good test at this point would be screening by doing a creatine kinase, CK levels.
Yeah.
CK levels are usually elevated, in muscular, dystrophies and things like that. So this was all about the neurology station. So, and this was examination of the lower limbs. Okay, so this was my feedback. Let's move on to the next station.
So what's my grade in this one? Borderline pass.
Yeah, borderline. Yeah, so
Okay.
borderline. Okay, borderline pass. So borderline pass, what is it? It could borderline fail as well, because then your performance depends on the other, like how you do in the others. They say some examiners, they look at that, like, if a individual is borderline, then look how he has done in the other stations. So if he's done good in other stations, they'll say, okay, well, fine. Give him a kick and pass him. Okay. So this is now an extended history and clinical examination station. This would be a 23-minute stations. You have been given a picture. Look at this picture carefully. So Alfie is a 10 months old baby. He is on home oxygen since he was born. And he's currently on 0.5 liter per minute oxygen. His mom is concerned about a wheeze, which is not going away since he had an attack of bronchiolitis 3 weeks ago. So he's on oxygen. He had a bronchiolitis attack 3 weeks ago, and since then the wheeze hasn't gone away. So the task is you have to take a history from the mother. So you've got like 8 minutes, 10 minutes for the history, 2 minutes for presenting your history, followed by 8 minutes for your general physical examination and a chest examination, and then 3 minutes for discussion with the examiner. So give it a reading. When you are ready, just let me know.
Yeah. There's my pen. Come on, so baby, please. Come on, so baby. Oxygen. Okay, can we start?
Okay, fine. So the time starts right now, please. So you can take the history from me. I'm the, let's say, the child's guardian or the parent.
Good afternoon. My name is Sheon, one of the junior doctors here.
Hello, doctor.
I've been
Pleased
asked
to meet you.
Hi, good afternoon. Nice to meet you. I've been asked to talk to you about your baby, Alfie. Is that okay?
Yes, sure,
I'll go ahead.
please.
Yeah, thank you. Yeah, so I was told you brought in Alfie because he's been wheezing the last 3 weeks
Yes,
since he
doctor.
had bronchiolitis.
Yes, doctor. I mean, 3 weeks ago we were here in your hospital, and he had a bad cough and he had a wheezy chest. And one of your colleagues saw him and diagnosed him with bronchiolitis. So he was given some medication through this what you call a nebulizer, and then he was referred to the ward. He was kept for a day because his feeding was a bit reduced. So, but in the next 2 3 days he became better, and we were discharged on some inhalers. And I don't know the name of the inhaler, but it was one puff 3 times a day for 5 days, and I've used that. But since then, the wheeze has remained. I mean, obviously, he hasn't got any cough at the moment. He hasn't got any fever, but that wheeze is not going away. I mean, he's wheezing on and off. And I went to my GP as well in between after, and he gave me a blue pump as well, and I've used that as well. But well, the wheeze is still staying. Sometimes it is bit more pronounced, sometimes a bit low, but it's on and off. So I'm quite concerned that the wheeze hasn't gone away. Somebody told me that the wheeze should go away within a week's time, and this is 3 weeks, and his wheeze is not going away.
Okay, so is this the first time he's wheezing?
No, he had a wheezy episode when he was 3 months old as well. But that was a mild, we didn't even come to the hospital. We just put saline drops in his nose and he got better with it.
Okay, so apart from this wheezing episode, do you have any other concerns?
No, it's just the wheeze that I'm worried about at the moment.
Okay, so how has this progressed since you've been in the hospital?
So, I mean, 3 weeks ago when he was in the hospital, the wheeze was quite bad. I mean, obviously, I mean, it was quite bad as compared to what he has at the moment, and he was like sucking under the ribs, and like his head was also bobbing. That has improved. I mean, he hasn't got any more he's not sucking under the ribs as well, but then he feels wheezy at times. I mean, especially when he's sleeping, so I can hear the wheeze.
Okay. Is there any history of lethargy? Is he drinking well? Is he feeding well?
Yes, he's feeding well at the moment. Yes.
Okay. There's no history of lethargy in him, is there?
No, he's not lethargic. He's quite happy in himself and quite active.
Okay. Are you worried about his stooling?
Oh, I mean, he is wetting his nappies and he's passing his tools, so I'm not worried about his
Sorry?
tools. I'm not worried
Sorry,
about
sir.
his tools. He's
Okay.
wetting his nappies and his poo is fine.
Okay. How many times does he poo in a day?
He's doing at least 3 times a day.
Okay. So can you tell me a little bit more concerning his birth? Because I can see that he's on oxygen.
Yes. Yes, I mean, Alfie was premature, so he was born at 30 weeks plus 5. And then we were admitted in the neonatal intensive care unit, and then they said he had probably sepsis, and they said it was a chest sepsis. So he was on oxygen. He was given antibiotics in his veins, and he stayed for around 3 weeks. And in those 3 weeks, he got a bit better, but then he got worse. They had to intubate him, and he was on a tube and a machine for 3 days. Then the tube was taken out. But since then, he has been on oxygen, and they told me that he has to remain on oxygen for some time. So he's
So
been on oxygen. Sorry?
how long was he on oxygen for? So he's been on oxygen since 3 weeks after birth, is it?
No, so when he was born premature at 31 plus 5. So I told you he
Yeah.
was there for a week in NI, 3 weeks in NICU, and since then he's been on oxygen. So right from that point in time, he's been on oxygen.
Okay. Did anybody mention, apart from, did they do any tests on him, any blood tests?
Yeah, they did a lot of tests. They did chest X-rays, and they did blood tests. And initially they said that he had some germs in his blood. And then they said that he's developing some water on his chest as well. Didn't know about that, but anyhow, he was treated with a lot of medications, and then a tube was put down his throat, and then he was on a machine, on a ventilator, and he was breathing through that, and then he got a bit better, but he's still on oxygen. I mean, he has been on
Did they
oxygen
do any
since then.
genetic tests on him? Sorry for cutting you short.
They
Did they
did
do any
some tests,
genetic
like
or
they
chromosomal
did
tests
some
on him?
tests, like did something on his heel prick, but they all have come back negative.
Okay.
And he had a brain scan as well, and they said that he had a bit of they said there was a bit of bleed inside his brain as well.
Okay. So has he been having seizures since then?
No, he never had seizures.
Apart from him being on oxygen, has he been a otherwise healthy child?
Yes, otherwise he's been healthy, yeah. Apart from that,
Okay.
that he gets a lot of VC attacks on and off, and since last 3 weeks, it's not going away. So
Okay. Okay. So so what's his nutrition like?
So he was tube fed in the beginning in the NICU, but since then, I mean, he was bottle fed, and now he's been weaned. So he's fine with his nutritional diet. I mean, he's gaining weight, and
Okay. Is he still is he on complementary feed now, or is he still on milk?
yes, he's on Similac too.
Okay. Okay. Is his immunization up to date?
Yes, he's fully immunized for his age.
Okay. Does he have any allergies, or what
Oh,
medication is
yes.
he on?
Well, he is not on any medication at the moment apart from oxygen, but he had a lot of antibiotics in the past.
Okay. So does he have any drug allergies or any other
No, he
allergies?
hasn't got any drug allergy. No, best of my knowledge,
Okay.
none.
Okay. Do you have any other concerns you like to talk about apart from this reason? Is there any family
No,
history
I'm
of
just
something
worried
like
about the
this?
wheeze, why this wheeze is not going away despite having tried different types of inhalers.
Okay. Is there any family history of this kind of thing visible
Yeah, I
within
mean,
the family?
my mom was asthmatic as a child. I am not, my sister is, and I don't know anything about his dad's side.
Okay. Um, um, what the family setting like? Does he have any other siblings? Yeah.
Sorry, I didn't hear that.
Does he have any other siblings?
Yes, he has got one elder sister.
Okay. Do you have any support for Alfie?
Well, we do have a support from a community nurse, which comes and checks selfies every now and then. The health visitor also comes, she weighs and gives me advice on and off, and has got regular checkups with the community pediatrician as well. It's usually every 3-4 months.
Okay. Are you working, or are you able to get some financial support from the government in any way?
Mm, Yes, I am on benefits. I'm getting some support from the council.
Okay. Okay. So do you have any other concerns you'd like to discuss today, ma'am?
No, nothing else.
Okay. Can I move to the examination now? Or
Okay, so before that, I mean, your time is up. Can you present your case?
okay. So I've spoken to Alfie's mom, who was the informant. Alfie is a 10-year-old boy that was brought in today because he's been wheezing. He's been having recurrent episode of wheezing, but the recent episode started about 3 weeks ago. Following which he's had bronchiolitis and the wheeze has persisted still then. He was born premature at 31 weeks plus 5 days. He had sepsis at birth. He was intubated and then he's been on oxygen since then. He's had different antibiotics. He was also tube fed from the beginning. He's presently on similar to and gaining weight. Mom is happy with the weight. Yeah. So yeah, Alfie is still currently waiting.
Fine. Would you like to do anything
information.
else? Would you like to ask any other questions?
Questions.
In the history taking, in like, or no, you are okay with it?
Maybe more about the review of the systems to review the other systems to be sure that they're not missing anything. Of course, Alfie doesn't have seizures or do he bled in his brain as bad as a child. I like to ask for developmental history, which I missed out. So to know what Alfie is able to do presently, if he's able to, if he has neck control, if he's able to sit without support, if he's able to sit without support, yeah, and then maybe he's beginning to crawl or stand with support. Those are the questions I like to ask to assess his developmental growth, motor developmental. His motor development. I also like to ask about if he's able to babble or if he has pencil scraps for fine motor.
Okay, fine.
I like to
Okay.
ask.
Okay, so that now brings us to the examination section of the station. So please do a general physical examination and followed by a chest examination.
So after asking for consent, I like to position properly gowned and gloved in a well-lit room. I like to ask mom to position Alfie on a lap, whatever. If Alfie is in the cot and Alfie is comfortable, that's fine. As comfortable as Alfie can be. And then, yeah, I like to start with doing a charting Alfie on a height and weight chart, and then doing a head circumference on an appropriate chart. Of course, I'll have done a corrected age, and then put him on a appropriate chart to see what centile he falls on. I like to look at that, do a brief inspection, properly exposed to remove his top to look at him properly to see what he's doing.
So he's happy with all his four limbs.
He's happy what?
He's happy, baby. I mean, he's smiling and he's moving all his four limbs.
Okay, that's very good. So I like to proceed to.
He doesn't look ill. I mean, he doesn't look ill at all.
Okay, so I like to proceed to do a brief general examination. I look at Alfie's hands to check for pallor. I also like to.
What are you looking for in hands? What are you looking for in Alfie's hands?
I want to see if it's pink. I want to look at his hands to see if we check for
Yeah, they are pink.
finger clubbing. To check if he have finger clubbing. By looking at his fingers.
There might be a little bit of early clubbing signs might be present.
Okay. I like to check for tinea and hypotinea eminence to see if there's any wasting.
It's not wasted at all.
I like to check his fingernails for sphincter hemorrhage and.
No, there are no splinter hemorrhages.
Okay, so I like to check for conjunctival pallor in Alfie as much as possible. Not to be stressing.
He hasn't got any conjunctival pallor.
Check if he has jaundice by pulling his upper lips up
No
and then
jaundice.
seeing if
No
there's
jaundice.
I want to look at his mouth to see if there's the mucosa is pink or if he has any central sinus.
Yeah, so his mucosa is pink. It seems pink mucosa. And
okay, I also want to check if he's dehydrated. Look at the moisture.
he's got moist mucous membrane. He's not dehydrated.
Okay. I like to see if he has any teeth eruption yet to check for dentition.
Yeah, can't. I don't think he has got teeth, but you can feel it when you put your finger. You probably can feel it. Something is just about to erupt from the lower gum.
Okay, I also like to look at his general appearance for any signs of dysmorphism. It looks like he has a receding jaw. It could just be the angle of the picture.
Yes,
yeah.
I mean, obviously, it looks like he probably has got a big head, but doing the head circumference, other things, it's just positional. It's just the picture that is showing that probably he's got a sunset sign. No, he hasn't got like any signs of hydrocephalus.
Okay, I also want to check for his how to put a measurement or paper or something to check for the level between his lateral canthus, what do you call it now, to his ear level to see if what do you call that line now?
Yeah,
I
so
want to see if he
he's probably got slightly low set ears.
okay, for research yes, okay. Also, I don't know if he has a prominent epicantic fold. I'm not sure now about the picture.
No, he hasn't got any prominent epicanthic folds. No.
Okay. So I want to check for his fontanelle to see if his fontanelle are still
His
open or
fontanelle is fine.
closed.
It's fine. It's soft. Fontanelles are anterior fontanelle is soft. It's not
Okay.
bulging.
Does he have a third fontanelle? No.
Pardon?
I'd like to check if he has a third fontanelle.
No.
Third fontanelle. Okay. So I like to examine his face chest now. I'd like to inspect first to see if there's any asymmetry. To see if the chest is moving with respiration. To see if there's any changes, rickety changes, or I mean, I want to
So
look at the chest.
Alfie chest hasn't got any scars. His chest seems symmetrical, and it's rising up with the breath. He hasn't got any subcostal recessions, and
Okay.
yeah, it seems fine.
Okay, so I like to palpate. I like to check for tracheal centrality, and I like to check for chest expansion by putting my hands on Alfie's chest and seeing if there's movement, and then if there's any, if the distance between my fingers is if the
Yeah, so trachea is central. The trachea is central.
I like to check for chest expansion too, and then I like to check for tactile fermeters, especially if he's crying. That will help. If he's crying, I could check for tactile fermeters. But if he's not crying, then I'll just move on and do a palpation quickly.
Okay, I don't think just sort of anterior posterior diameter would be of any help in a child of 10 months age or vocal parameters. But anyhow, for sake of simplicity, I would say it is normal.
Okay. And then I can quickly percuss over his chest anteriorly, and then I like to
Yeah, so the
listen to
sounds
his
are
chest.
resonant. His sounds are resonant on both lung fields.
Okay, I like to listen to his chest anteriorly on the anterior lung field, on the sides and middle, and then at the back bilaterally.
So he has got a prolonged expiratory phase on both sides, and he's got scattered polyphonic wheeze on both sides.
Okay, so I like to listen to his cardiac areas also.
Where would you listen to cardiac areas?
Sorry?
You listen for the cardiac sounds.
Yeah, I like to check if there's activity of his precordium and put my hands and then palpate if there's any heave or trail. Then I like to listen to the cardiac areas in the fourth intercostal space, the second intercostal space on both sides, and then the lateral lower sternal
So the heart sounds are fine, and there is no murmur.
Okay. So you just want me to examine the chest, right?
Yes.
Just chest examination, yeah. So I can finish by checking for, just to be sure that it doesn't have any, checking for hepatomegaly, just to be sure
Yeah.
that we're
So
missing it.
so the liver border is palpated 3 fingers below the right costal margin. What else would you like to do?
3 fingers. I like to palpate it to see if it's tender. Yeah.
It's not tender. It's not tender.
Okay. So the chest examination I wanted me to do, right?
Yes.
Yeah. So I want to check the fit for. Sorry, I should have done that during my general examination for pedal edema or sacral
There is
edema
no
rather,
edema.
not
Okay, no edema.
pedal
Fine. Okay, so we stop here because the time is up now. Can you formulate your differentials for this child?
Yeah. My first differential will be a chronic lung disease background with maybe exacerbated by viral infection. That's
Okay.
resolving.
Okay.
Resolving.
And what name would you give to that chronic lung disease
What name
based on
do I
this,
give
based
to?
on the history and examination?
I'm not sure I understand that question.
Like
Chronic lung
what sort of
disease.
chronic lung disease? Chronic lung disease is an umbrella term. What do you mean by chronic lung disease when especially when you have taken the history, you know the history now and you know the examination finding. So what do you think is the most probable diagnosis in this particular case?
Name do I give to the chronic?
Okay, fine. So we move on to the next question. What advice would you give to this child's mom?
Yeah. Sorry. You said what
What
other
advice?
test to learn?
Pardon?
Yeah. I'll have loved to check for saturation. That's very important. Very missed
Mhm.
out. Yeah.
Yes, its saturation is
Yeah.
98% on room. Yeah.
Okay. So if his saturation is 98%, he's happy. Is on 0.5 liters of oxygen, hopefully, which has not changed because it's always been on oxygen. You probably won't go lower than 0.5 liters anyway. So it means the situation has not really changed. Happy is happy, happy is feeding. So I'm just going to reassure the mom and then counsel about the red flag signs, which include increased need for oxygen, increased difficulty in breathing, reduced feeds less than 50%. Of what you would normally take, lethargy, which is very important. So if he stops being happy, sleeping all day, it's difficult to arouse, he just wants to be
Okay,
left
that's good.
alone.
One last question. What is the reason of for we staying so long?
The wheeze, because Alfie already has, for lack of a better word, his lungs has been under stress since he was born. So his lung capacity will not be as functional as the baby that he had this experience. So of course they told moms that bronchiolitis will resolve within 2 weeks, but for Alfie that may not generally be true. So I think he's still in that phase where he's recovering. Yeah, I think that's what's going
Okay,
on.
fine. So the time finishes for this station. So this was an extended history and clinical examination station. So you performed relatively well on the history side. Uh,
Bronchopulmonary dysplasia. Bronchopulmonary dysplasia. That's the word I was looking
yes, you're very right. So this was a case of bronchopulmonary dysplasia because the history and the finding. So if a child is oxygen dependent, you know, at day 28th of that, so that is bronchopulmonary dysplasia, which is another name for chronic lung disease. And obviously the history of being premature and then being on oxygen and then intubated and then never been off his oxygen is going in favor of what we call as BPD, bronchopulmonary dysplasia. And bronchopulmonary because it's a dysplastic lungs, so obviously they are more prone to infections, and if they have got even viral, so usually the residual symptoms stay for longer as compared to the normal child. So like the advice to the mom was very right that you need to tell them that because he's got dysplastic, chronic lung illnesses, so his lungs are quite weak and they cannot function like an ordinary child's lungs would work. So that's why when these kids have got infections, they stay for longer. They have to be treated a bit more aggressively, and the residual symptoms, they stay for longer as compared to the normal children. But as long as he's a happy child, he has got increased work of breathing, his sets are fine, his feedings are fine, then you don't need to worry about that. Another differential in this case could be gastroesophageal reflux. Obviously, gastroesophageal reflux can be exacerbated by these episodes of bronchiolitis, and given the fact that he has been having repeated infections and repeated V's over a prolonged period of time, so gastroesophageal reflux could be another possibility. And obviously, he had some bleed. The scan showed some bleed, so there might be like grade 1 intraventricular hemorrhage, and obviously that usually sometimes interferes with the feeds and other things, so that can lead to aspiration as well, lead to gastroesophageal reflux. So these are the two things that you should keep in your differentials. Now, as far as the examination was concerned, obviously the clue is, obviously you can see, from that I see a 10 months old happy baby who doesn't look ill because he's quite happy, he's smiling, and he is on oxygen. It's very important that when you are doing your inspection part, you have to look at the surroundings and comment on that. They are looking at that, and they would mark you on that. So you can't miss that he's a child on oxygen, he's got nasal prongs, and he has got attached the what you call sticking, by which the nasal prongs are attached. And obviously, if there are any other findings, but he doesn't look well, and then after that, what you'll do is I will properly expose the child to see his build, his color, look for any dysmorphism, look for any activity, look for surroundings if there is anything else apart from that. I mean, obviously, I can see the half of the picture, but if there are any other, like sort of medications around the, and then you have to start by examining. Basically, you start with the hands, and you look for cyanosis, you look for clubbing, you look for anemia, you check the pulses, and as you go up, you will be checking. Yes, one thing more. When you are finishing any respiratory examination, so always say at the end of respiratory examination that I would like to finish off examination. Obviously, you mentioned about that by looking for hepatomegaly, and if there is hepatomegaly, I would like to check for liver span, because it might be a downward displaced liver because of repeated. It could be, rather than having being in heart failure, which doesn't seem to be the case, provided the fact the child is so happy and hasn't got any other distress. The other thing is, always say, I would like to finish off my examination by doing the ENT examination, so the ears, nose, and throat examination. So that is very, very important whenever you are doing a respiratory examination, to see that there is no postnasal drip or something which is causing, a repeated cough and these types of issues. So that is important. And then say, well, I would like to plot Alfie, and you said it in the beginning, but it should be, you keep it for the end rather than doing it at the beginning of the general physical examination. You do it at the end, and I would like to plot him on the centiles chart, his height, weight, and head circumference. How would you manage this case? They might ask you, well, I would give reassurance to the mom, and do some safety netting, telling her to have a follow-up with the GP after a few days. Obviously, safety netting also means that, as you told, that if there are like any red flags or something, she should immediately come back for help. And obviously, follow up with with his regular appointments. I mean, if he's under a pediatrician or something, I mean, obviously, you should have asked in the history in the beginning when you were taking history. One thing that you missed, you missed the developmental part of the history, which is very important because he was premature. So developmental, and obviously the prenatal, you should have asked why he was premature, what was the reason of being born. And the other thing is that you should also ask if he is under a pediatrician, okay, and whether he's been regularly followed with. So that in that case, you'd say, okay, well, fine, I would write to your pediatrician as well about this sort of interaction with me, and if there is any question or something, we are always here. You can come back to us anytime. So this is how the approach should be in an extended history and clinical examination station.
Okay.
Fine. So we move on with one final station. We will do the communication later on. We will do this video station. Okay. So I will
that was
play.
also a borderline pass, right?
Pardon?
I said that was also a borderline pass.
Okay. So this is a video station. So you have to look at the video. and note down the findings, and then I will have a discussion with you. Okay, so let me start the video. Christian. So, what are your positive findings in this video?
Well, the video showed possibly an infant in a like a Moses cot, or what do you call it? A baby cot that looks like a swing. She appears to have or she appears to be comfortable, not in any painful distress. Maybe from the view here, her head looks small, like she has a microcephaly. She was having repeated movements. It was more flexion of her lower limbs. Then I thought at a point like a shadow behind came to check if she was aware, and I wasn't sure if she was. Yeah, I think that was those were the things I saw.
What do we call these types of movements?
Well, it's difficult to tell, but it could be a kind of seizure.
What's the name given to this type of seizure?
It doesn't look like the typical Salim attacks. I wasn't sure if it was absent seizure she was having because I couldn't really see the eye movement properly. I think I'm torn
Absent
between
seizures are
two.
usually not common. They are more common at around 3 years of age. If you see, the movements were
Yeah,
like sudden flexion of the upper limbs, there's flexion of the neck going down, subtle.
yeah,
There was like an obvious flexion, and probably that happened 6-7 times in 1 minute, along with the flexion of the lower limbs as well. So
yeah. Is it a Salim attack? Is that what it is?
yeah, so these are known as flexor spasms.
Yeah, flexor
Flexor,
spasm. Yeah,
flexor spasms.
yeah,
Give me two
yeah.
differentials for flexor spasms. What causes flexor
Tuberous,
spasm?
tuberous sclerosis,
Yes, tuberous
and
sclerosis.
it's part of the syndrome they call the
Yes,
West
West
something
syndrome.
syndrome.
Yes, you're very right. So West syndrome and tuberous sclerosis are two the differentials. What would be the investigation of choice in this particular condition?
I like to do I like to do an EEG. Yeah.
Yes, EEG. So what would EEG show? What would be the
Or
characteristic findings on EEG?
ipsilateral waves on EEG 3 to 5
No, 3 to 5 is actually absent seizures. You are talking about 3
that's
spike and
absent
wave
seizure,
pattern. That
sorry,
is
sorry.
absent seizures.
Ipsilateral ipsiarrhythmias are
Yes, hypsarrhythmia. So this is hypsarrhythmia. So hypsarrhythmia. Two drugs of choice.
Some people give high dose steroids. Some people give ACTH, I think. I'm not
Yes,
mistaken.
ACTH. And
Yeah.
the other one?
ACTH, and then I think they used to give steroids for. I'm not sure if they still do or not.
Steroids are not used these days. It's ACTH. But what's the other drug?
Vaga,
Mycopatrin. Okay.
Vigabentin, yeah,
Vigabentin, yes,
vigabentin.
that's fine. Okay, fine. So this is a pass for you on this video station. So if one differential of flexor spasms, that could be gastroesophageal reflux causing, like, but that causes more of an extension, that is Sandifer syndrome.
Mm. Yeah.
They usually arch their backs, and become tightened. So these are plexus spasms, and there are two differentials for that. One is tuberous sclerosis, and the other is West syndrome. West syndrome is associated with microcephaly and has got a very poor prognosis. So this is the only condition in which you have to do an EEG in the next 24 hours. So this is an EEG, like the EEG has to be done in emergency. And if the EEG shows characteristic hyperarrhythmia pattern, then the child has to be started on ACTH or vigabentin, especially if the child has got tuberous sclerosis and, there are stigmata like Chagrin's patch and, a hypopigmented patch on the skin.
Yeah.
Fine.
Yeah.
So that brings us to the end of today's session. So we did an extended clinical, we did a video station, and we did a clinical examination one. So
did I pass or fail?
So this one was passed. This one was passed.
No,
Yes.
overall, if you pass or you fail, come back with a receipt.
Yeah, so this one was passed.
Okay. Thank you for
So
your
we
time.
will do some more stations tomorrow.
Okay.
Okay, we'll do some more
What
stations
time
tomorrow.
tomorrow? What time tomorrow?
So I will then message you.
Okay. All right then.
Okay. So all the best and have a good evening.
Yeah, it's been quite long. I had my brain stimulated, so I'm not firing at a subliminal fringe. It takes time of practicing it.
Yeah, that's fine. That's why we are doing all this practice and thing.
Yeah. All right then. Have a good evening, Dr.
Okay,
Kasi.
thank you. All the best. Have a good day. Bye-bye.
Bye. Cheers.